Okay, here we go on blood. Um, there's four excellent websites you might want to think about going to first. Let me find out where they are. Visual MD, man, this is phenomenal. It's got all sorts of things on cardiovascular as well as other areas, but the photography here and it is just amazing. And also there are narratives and short videos by doctors explaining things. The Visible Heart, what's really nice about this, one of the strengths is video library. Everything from disorders of the cardiovascular system to cardiac output. Same thing with MedMovie. Lots of different things. I'm in the area on heart. You can see there's a whole bunch of animations here. And HeartSite, really great explanation. So movies, MedMovie, and Visible Heart, explanations and wonderful pictures, as well as some animations. Visual MD and welcome to the HeartSite. So those are excellent resources. Okay, big chapter, important chapter. This is going to set you up for the next chapter on the cardiovascular system part 2, which is on circulation. All right, so location. You had this back in chapter 1, but let me remind you. Let me go over to my stuff. Okay, so I've put in a kind of a red area here, the area called the mediastinum. It's sitting in the much bigger area right here called the thoracic cavity. What is missing right here is the diaphragm. It would be sitting right there, pushing up against the lungs. Lungs are sitting on it. You can actually see some of the diaphragm right there on that bottom shot, and you can see a good shot of the diaphragm right over here on the dissection. So anyway, that's the thoracic cavity, and then this middle area is the mediastinum. You can see the aorta sitting there. You can also see a little bit of the trachea right through the a couple of the branches of the coming off the aorta. This thing right here is not the aorta, it's the esophagus. The aorta actually comes up like this, and there's the aorta going down. And then there are bronchi branching off the trachea. And of course the heart is going to be sitting right there. This whole thing is called the mediastinum. Media, middle. So look over at the right over here. You see a really good view of the heart, and you can see it is sitting in a cavity that looks like black. That's the pericardial cavity. And there is a membrane. You can just make out maybe right here. I'm putting blue dots on it. A little bit of the membrane. It's sitting around like that. Obviously there's fluid in between. Here's a much better look of the pericardial sac right there. We'll talk more about it in a minute. Look how I drew the heart like that. It's pushing over to the left. You know that you pledge allegiance with your hand a little bit over to your left. 2/3 of your heart is to the left of the midline. You can really see that well right there. You are looking at a cut section, cross section, horizontal plane of the body going right through the heart. This is left and this is right. The heart is sitting in that cardiac notch carved out on the lung. By the way, you can see a really great picture of that cardiac notch right there. And you can see the pericardial sac that's been cut away to expose the heart, and of course the fluids come out. Okay, so that's called pericardial sac. There are two parts of that membrane, and you can see in an enlarged view down here at the bottom right, two membranes. This membrane right here, this membrane right here. This outer membrane is what's actually forming the sac. There's an outer, it's mostly connective tissue more than anything. This is the fibrous pericardium, the most of the sac, and of course there's a fluid in between, you know, right in here. I'll put dots right there. That's the pericardial cavity. Now, if you follow that pericardial sac, you can see it dead ends, and then it comes out and it becomes the actual lining on the heart itself. That is called the visceral layer of the pericardium. Remember, parietal layer, visceral layer, serous membranes. Serous membranes come in pairs. They make fluid, serous fluid, pericardial fluid, serous fluid. So, again, the serous layer, that is the pericardial layer, is the outer, and the visceral layer is the lining on the heart itself, and it's usually called the epicardium. That's the other name for that serous layer. Then you've got the thickest portion right there. This is cardiac muscle, myocardium, myomuscle. And then on the inside where the blood's hanging out, you've got this membrane called the endocardium. You can have irritations of any of these membranes. You can have endocarditis, pericarditis, what am I missing? Epicarditis. Alright, I've already introduced you to layers, so there's not much to say about that. Good view of the 3 layers. Cardiac muscle, you've had it already. I got a high power 40x histology slide right here. Let's see, let me get to a check. Nope. Well, somehow I got rid of my check there. Right here is an intercalated disc. Here's another intercalated disc. There's another intercalated disc. You see them right over here. Remember, these are specialized gap junctions so that cells can communicate with each other. It increases the movement of the depolarization wave through the muscle fiber. Remember, this is one muscle cell right here. They're short muscle cells. You can see a nucleus right there. Look at these little striations you see right in here. All right. Some key things you see. These guys don't reproduce. They die. They're damaged. They're goners. Involuntarily controlled. The muscle fibers run in parallel bundles wrapped around the heart. You can see a good view of that over there, kind of like wraps. As if you were wrapping like an ace bandage or something around and around and around and around, you know, the way you do it, go up and down and around. That's called a syncytium. There's one of these wrappings around the atrium and one around the ventricles. It helps with a really good squeezing and contraction of the heart. Aerobic respiration. You deprive the heart muscle of oxygen, it dies. Its nutrient source, mainly fatty acids. Remind yourself about differences of cardiac muscle from smooth muscle. Okay, so let's go over to, oops, that's not where I wanted to go. I'm trying to get, nope. Let me get out and get where I'm trying to go. Okay, I might as well just jump over here since it's not going to go where I want it to. All right, so here's another view, a lower power, a little bit about the same as your earlier picture that I had of the cardiac muscle right there. But here's a diagram showing the parts of muscle. Remember this, A bands, I bands, blah, 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 blah. It's pretty much like skeletal muscle, a little bit difference in the T-tubules that's not important to remember, but anyway, there's one of the major difference areas. Okay, we're going to spend most of our time in lab really going over the anatomy, and I'm going to take you through it in a minute, but you know that there are 4 chambers, atria and ventricles. Um, you've got an atrium, you got an atrium, you've got a ventricle, you've got a ventricle. Over here is going to be the left side of the heart. This is the right side of the heart. I'm sorry, you can't look at it from your left and your right. Okay. Notice that there is a wall, and you can't see it, but that wall goes up behind the 2 big blood vessels right here. By the way, this is the pulmonary trunk, and this is the aorta right there. This is called a septum, and so it divides the heart into 2 pumps. The blood doesn't go directly from left to right, right to left, okay? There's no mixing of the 2 between the 2. Well, there's one exception, but that's a problem in the newborn. Anyway, we'll talk about that later. Other vessels. I've pointed out the 2 major arterial vessels. The aorta is the major artery of the body. Pulmonary trunk, which comes up and it splits into a trunk going that way to the left lung. And you can't really see it, but there's another trunk coming off, and it kind of goes behind the aorta, and it goes behind the vena cava. That's a superior vena cava right there. And the other artery comes in this way and goes to the lung. So it forms a T. That's why it's called a pulmonary trunk. I mentioned the superior vena cava. Here's the inferior vena cava down here. Notice, and again you'll see this when we do the pig, the 2 ventricles. These guys are the major pumps. They do 75% or more of the work. But look at the left and look at the right, and you'll notice the right is kind of half-moon shaped, because the left, which keeps more of its structural integrity, is kind of pooching over into the right. The right actually could potentially hold more blood. Now, the 2 actually fill with the same amount of blood and pump out the same amount of blood. But notice that the left, the myocardium, is really thick, way thicker than what you see over here on the right. And you can see that the actual lumen, the area where the blood is much smaller. Now, the reason why the thickness of that wall is so important is because it's pumping into the aorta. The aorta carries that blood to the rest of the body. Where does the right ventricle pump to? The lungs. The lungs are only a few inches away. I mean, how much pressure do you need to get the blood? A couple of inches. So the pressure is going to be humongous here on the left side. Keep that in mind. It's going to come up again to haunt you. The valves. Let me get rid of all this stuff and point them out. These are called AV valves, atrioventricular. The guy over here, bicuspid valve. The guy over here, tricuspid valve. The bicuspid valve, by the way, is also called the mitral, and you might remember that mitral has an L at the end, and that L stands for left side, and the tricuspid has a TR following the T and the R for the right side. You're going to have to get that right. And of course, these valves are going to open up, and the blood is going to flow from atria to ventricle. The valves prevent the backflow. We'll talk more about it from going back up. All right, now you see a valve right here. This is one of the semilunar valves. Their valve flaps are half moon shaped. This one is in the pulmonary, remember, so that's called the pulmonic valve. And you can't, well, you can just barely see it. I'll point out where it is right there. You can see a little bit of the aortic valve, and that's called the aortic valve. So moving on, blood flow. Okay, I'm going to take you through blood flow in just a minute. I've already mentioned left, and right side of the heart. Left, oxygenated blood. Look, I colored it, highlighted it bright red, highly oxygenated. It's coming from the lungs. It's going to get pushed out to the body. Right side, it's going to the lungs. It's going to be dark red. Remember, it's low oxygen. It's not going to have that light red color of oxygenated blood. So you definitely need to know the route through the heart. You need to know the differences between the left and right sides. Okay, so let's go into this. I'm going to do some blood flow here, and I guess I'll start with the blue side first. Okay, so we're going to start on the blue side. Remember, we're coming in from the body, lower body, coming up this way into the inferior vena cava. From the top of the body, arms and all that, coming down this way. All right, so blood goes into the superior vena cava. It goes into the inferior vena cava. Blood comes in. Blood comes up. Actually, the two meet together in the back. You can't see them, but they come together. And they open up. There's a little hole going into this right atrium. Okay, the blood is going to get pushed from this right atrium through this tricuspid valve, and it runs down into this wall that's in the way, and as the ventricles contract, this blood is going to take a U-turn and go up through this way into, remember, this is the pulmonary trunk. There's that split to the left lung. You can just make out some of the split going to the right lung. You got to know this circulation. Okay, let me change colors. Let's go to red. Okay, so now we're going to come in from the lungs. Okay, so lungs. And again, you got a left over here, and you got a right over there. And from the left, you see coming in here, pulmonary veins. And you can't see them, but there are pulmonary veins on this side coming in from the right. They'd be sticking out this way. They've just left it off the picture. Anyway, so blood comes in this way. And again, from these veins coming in on the right side, blood comes in that way. There are 4 veins coming in the back side of the heart. We're now in the left atrium. We go through the mitral or bicuspid valve. We get down in here. There's no place to go. We do a U-turn. We go through the aortic valve. We're now into the aorta, and the blood is going to move out these branches and keep on going around the aortic arch, down. Eventually, you don't see it, but the aorta, there's a descending aorta coming down this way, going to the rest of the body. These 3 branches up here at the top I drew. I'm not going to get into them right now, but they go up to the head and to the arms. There are 3 branches in humans coming off the aortic arch. Wanted to point out there's your pulmonary or pulmonic valve. You've got to know this flow. No way around it. Okay, valves. We're going to get more into these valves. I'm sure you've all been at the doctor where they take a stethoscope, put it on your heart. All right. And on your chest and on your back and so on. All right. So there are 4 places on your chest where you can really see these, hear these valves well. Now the location of the valves is shown on this picture. They look like dark ovals. But in green is where the stethoscope is put to hear the valves the best. So you don't actually put the stethoscope bell on the location of the valves. So the most important one, I guess, we'll say, is number 1. Number 1 is the bicuspid valve, the mitral valve. 2 is tricuspid. That's the one between, on the right side between atrium and ventricle. And then you've got the semilunars, 4 pulmonary, 3 aortic. Now, I mentioned number 1 is the most important. So let me remind you, let me get out of this and go back to a different picture to remind you. I pointed it out. There it is right there. Okay, So remember that the left side is pumping to the body. Remember that the pressure right over here, this is the left ventricle. The pressure, because of the thickness of that wall, is huge. It's 6 times higher pressure than the right side. Now again, you're pumping out the same amount both sides. It's the pressure that is the difference. And the reason is you got to get that blood all the way out to your toes. Now that means that there's going to be way more pressure on the left AV valve. Remember that the left AV valve is the one between the left atrium and left ventricle. It's the bicuspid. There's not as much pressure, 1/6 of the pressure on the right AV valve. So that bicuspid valve is most often the one that not comes apart, but fails, and it very often has to be replaced. Okay. So here's a look at those valves. Now, you're looking at the top of the heart. Let me point out first, get rid of that. All right, so here are 2 semilunar valves right there. Again, they look kind of like 3 little flaps together. And here's a view of it. Remember that the blood is going to come down this way, and it's going to go out that way through the valve when the heart contracts, when the ventricle contracts. When the ventricles relax, the blood is going to want to sink back down again. The blood gets caught in these little flaps, and the flaps hold together, and the blood can't drop. Okay, so that's the way the semilunars valve. They just kind of catch the blood and fill up, and boom, they catch the blood. Now, the AV valves are different. AV valves, their job is when the ventricle contracts and the pressure inside of here goes way up, you want valve flaps to keep the blood from getting pushed back up into the left atrium. Those valve flaps close due to the pressure of the blood in this area. The valve flaps close. There's no place for the blood to go except out that blood vessel, either the pulmonary trunk or the aorta. That's what they're for. The valve flaps don't push blood around. That's not what they do. They don't push flow. So they passively open up as the blood comes through into the ventricle. And when the ventricle contracts and pressure goes up, the valve flaps are pushed closed. Now the AV valves are closed, but the semilunars are going to open because the blood is going to go through those valves and push them open. You can see some views of these valve flaps. You can make out some little stringy guys right here, and you can see them right here. These are called chordae tendineae. That's what keeps the valve flaps from flipping upward. You don't want the valve flaps to kind of flip upward like that. That would allow blood to regurgitate upwards. So those little chordae tendineae keep the tips of the flaps closing well without flipping backwards. Now, at the bottom of the, by the way, you got a good view of chordae tendineae in there, looking down. Notice that there's like a mound of muscle projecting right here where the chordae tendineae attach. Those are called papillary muscles. They're like big stanchions of muscle that tie to those chordae tendineae. We'll talk about valve problems later. Okay, the blood supply. Heart's got to have blood. It's got to have oxygenated blood. You would think that it could use the oxygen from the blood inside of the chambers, but no, that blood's not staying there long enough. The wall's too thick, blah, blah, blah. Okay, so let's go arterial supply. Now, you'll probably at some point in time have to learn this in more detail, but more detail than you need to know at this point about the different branches of the aorta. Okay, so remember, the blood is going to come out. It's oxygenated from this left ventricle, and it comes out this way into the aorta. Now, right there, where the aorta starts, well, a little bit further, there is a branch coming out here, and there's a branch coming off here. Let me get rid of this so you can actually see it. Okay, so there's a, maybe I can make a smaller, there's a branch there, and there's a branch there. These are actually the first branches off the aorta. These are coronary arteries. The left coronary artery comes off right over here, and then it branches again into a couple other, they have other names. The right one comes down this way and branches off. Now, this main guy right here, I'm putting some red on it right there, making it thicker. This is the interventricular. It's the main one going down into the septum, feeding the area between the two ventricles, particularly most of the left ventricle. It's sometimes called the widowmaker because when that clogs up with cholesterol or there's a clot, your odds are not good because it's that left ventricle that's most important. Okay, if you have a problem in those arteries, they're carrying blood to heart muscle. You got coronary artery disease, CAD. This is a problem in the coronary artery. If enough oxygen is not getting in there, you have symptoms, at least many people do. It's a pain in the chest, in the arms, shoulders. Sometimes people think it feels like indigestion. It's called angina pectoris or angina. That's a signal to stop whatever you're doing, stop eating, come in from the cold, stop exercising. If you don't, that tissue being deprived of oxygen is going to die. That's going to precipitate a myocardial infarction, a heart attack. Myocardial, obviously, what it is. Infarct, death. There's no going back at that point. Angina is a signal. By the way, remember that's a type of referred pain. Causes, I've already mentioned cholesterol. It could narrow the area. It could be a clot. Those are probably the two major ones. Effects, I've already gone through that. Treatment, real briefly, they can give a dilator, vasodilator like nitroglycerin to make those vessels a little bit bigger to carry blood more effectively. They can go in and kind of ream out your coronary artery. They can put a bypass, lots of different things. Okay, venous supply. You got to drain the blood that has high CO2. So, look at the picture of the heart here. Now, these are called cardiac veins. They're not called coronary veins. Sorry, I didn't name them. Get over it. Okay, so they're coming up this way. There's some branches. They come around the backside. Now, notice that the blue becomes a lighter blue. That's trying to tell you that you're on the backside of the, it's going around the backside of the heart. You're looking at the front of the heart, but these vessels go around the backside here, goes around that side, and right over here, remember this is right atrium right there. There's another little hole right here where that blood comes in. By the way, this area right in here is called the coronary sinus. You can see it on the heart models. It's where all the venous blood congregates before it comes into that right atrium. Okay, so going to the conduction system. I've gone over all the anatomy here. Let me point out where we are then. There are four tissues. They are heart muscle cells. They've lost the ability to contract. Their job is to produce action potentials and transfer cell-to-cell action potentials all the way to the ventricles for contraction. Let me point them out here. SA node, sinoatrial, right there in the right atrium. There's your major pacemaker. In fact, there it is right there. All right. The second one is the AV node. It's sitting right there. It's right there at the boundary between left sorry, did I say left? We're on the right side, sorry. On the right side, between right atrium, right ventricle. Then we've got the AV bundle, and the bundle comes down this way through the septum, and it splits in here, and it splits into a couple of branches. These are called bundle branches. You can see there's the AV bundle, and then it splits into bundle branches there. It comes down around the bottom, and this is where it actually gets to the ventricular myocardium. And these are called Purkinje fibers down around the edges here. Each one of these conductive tissues can generate its own impulse rate, its own rate of action potentials. The SA node is the most important because it is going to release the fastest impulse rate at 70-ish action potentials or beats per minute. So you can see what one of those action potentials look like right there. That impulse goes down. Oops. Trying to get the... There we go. What was I going to say here? Somewhere. Over here in this right atrium, we get a release of the impulse. The impulses move through the atrial areas into the muscle. That chamber, both chambers at the same time, are going to start to contract. The action potential gets down to this AV node. AV node then relays that down the bundle through the branches to the Purkinje fibers. So this guy starts it right there. This guy relays it to here, which relays it to there, which relays it, this guy, directly to the ventricular muscle. So this guy is the key guy. He's the one that sets the rate. Now, if he's destroyed in any way, either totally or partially, then what happens? Then the impulse is going to slow down. If there's a little bit of damage right in here, it may still be able to generate an impulse, but it may more slowly get to the AV node. Then, of course, your heart rate's going to drop. If this were totally damaged, the AV node will take over as pacemaker. Each one of these guys can generate its own impulse, but they're slower than the SA node. So really, for our purposes, unless you're in a coma and you don't need a very slow heart rate to do anything, you've really got to have that fast release from the SA node. So, arrhythmias. Problems in heart rate, problems with conductive tissue. So, heart rate changes. Too fast, too slow. By the way, arrhythmia means without rhythm. Bradycardia, slow, less than 60 action potentials, beats per minute. Tachycardia, too high, over 100. Causes could be your mental state. You're anxious, you're fearful, higher heart rate. You're depressed, lower. Alcohol slows your heart rate. High temperature, you're sitting in a hot tub, heart rate's going to be faster. Hypothermia, you're cold, slower. Medications, all sorts of things. Okay, ectopic foci, that's plural. One is called an ectopic focus. This is like a rogue action potential generated by conductive tissue, or sometimes heart muscles will produce it. And they produce contractions where there shouldn't be a contraction. If this happens a lot, they can do a laser, it's called ablation, where they go in and burn that little area if it's generating these impulses consistently. You have to get rid of it. Okay, staying up many days, lots of medications, too much caffeine, lots of different things can cause it. Okay, heart blocks. Remember, let me go back to the previous shot. Okay, so remember, here's your action potential. Let me make my thing bigger. Okay, here's your action potential right here. Here's the route it takes to the AV node. And then from the AV node, it's going to go down the bundle. If, let's say, there was damage right in this area due to a heart attack before, look what's going to happen. It's going to come this way. Either you could have a complete block, or if it's just a partial, it could get through, but it may be slowed down. Okay, so that's called a heart block. And in severe cases, they may have to put a pacemaker in. You see lots of different examples of pacemaker pictures. Flutter and fibrillation. Now we're really out of control. This is incoordination of the heart. We're talking about over 100 beats per minute. Fibrillation is something over 200 beats per minute. You would think that the faster the heart would go, the better the blood flow would be, but when you're at that speed, the ventricles can't fill with blood properly and your cardiac output is going to fall. We'll talk about that more later. Flutter is not as bad as a fibrillation. You can have a atrial flutter. That wouldn't be as bad as a ventricular flutter. Remember, ventricles do most of the work. You can have a ventricular fibrillation. That would be very bad. So obviously you see a picture of defibrillation. You can do CPR. You can give a chemical defibrillator, chemical like procaine, something like that, lidocaine. You can use those electrical paddles. They basically stop the rogue, out of control action potentials that are giving incoordination among the chambers, and hopefully the heart will reset itself. That is, the SA node now picks up the normal beat, or they may have to do other things. Okay, I'm going to stop here and I'll do a second one of these, part 2.